Good evening, everybody. Tonight, this is my honor and pleasure to co-host this great event with one of my closest friends in Europe, Emmanouil Brilakis from Greece. And the topic is pretty hot tonight because we're going to talk about bone loss management in reverse shoulder arthroplasty. I'm sure we are all able to perform a great shoulder arthroplasty, but when it comes to bone loss, maybe we need some tips and tricks to get it right. And that's why we're going to have an exceptional faculty tonight. As you can see in the program, we're going to talk first about glenoid defects, so how to classify and how to manage, and we're going to do the same with humeral bone loss, how to classify and how to manage. And you can see the faculties from all over the Europe, so we're going to have Catarina Angelo from Portugal, Olivier Verborgt from Belgium, Franceco Franceschi from Italy, and Deborah Higgs from UK. I would say the biggest name in the field, just to teach us how to treat bone loss and reverse shoulder arthroplasty. My pleasure to introduce one of the most talented younger surgeons from Portugal, Catarina Angelo. She will talk about glenoid bone defect classification.
Hello everyone. Hello Maristella, hello Manos. Thank you so much for having me here today. Thank you SECEC for organizing this amazing webinars. We're very, very lucky to be able to access all this content for free. So if you're not a SECEC member, I just wanted to invite you to join us. This is an amazing society getting better and better. So with no further ado, I will share my screen. It's an honor and a pleasure to start this webinar today, especially talking about something that I think that any shoulder surgeon loves, that's the glenoid. So these are actually what you see on screen. There are many glenoids of some of my patients. So as you can see, you can have many different shapes and many different types of glenoid. You never know what you're going to get in your menu. So today I'm going to talk about how to classify and how pre-op planning and understanding the shape of the glenoid that's in front of you, it's going to influence on your reverse shoulder arthroplasty. Okay, so these are my disclosures, nothing specifically related to this presentation. And we all know that the glenoid is the base of your upper limb. So the glenoid takes all the weight of the upper limb and behaves as a link between your axial body or axial skeleton and the upper extremity. So it's a very, very important point of our body. But there's a small problem. The glenoid is tiny. So if you want to replace the shoulder, when you want to implant something on the glenoid, you have very limited bone stock, and this is usually a problem. But it's not the resources you have, but how resourceful you are with what you have. So here we just have to become resourceful. We have to understand why do we have this amount of bone and how can we successfully place an implant in this small amount of bone with success. So going back to causes, what causes glenoid bone loss? Understand and then act. So these are the major causes of glenoid bone loss. And when we do our primary cases, we usually deal with primary glenohumeral osteoarthritis and rotator cuff arthropathy. When we do our revision cases, usually we deal with glenoid loosening or glenoid component failure, more commonly after a reverse shoulder arthroplasty. So when we do our primary cases and deal with primary glenohumeral osteoarthritis, what we usually get is a posterior and or anterior wear. When we deal with rotator cuff arthropathy, usually we get a superior wear. And this is what we should expect. So we all know very well the Walsh classification of primary glenohumeral osteoarthritis. This was described in 1999, initially with 3 types, type A, B, and C. Later, 2 types were addition to this classification. So the D type, which is an anterior wear, and the B3 type, which is an uniconcave posterior wear. And what we know nowadays is these are not different types of glenoids. but different stages. You caught this patient in a specific state of their natural history of their disease. What we know nowadays is between 5 to 15 years, 100% of B1 glenoids eventually evolve to B2, and 40 to 55%, so more than half, can evolve from A1 to A2, and from B2 to B3, and this usually implicates bone loss. So we have this tiny glenoid, which is already a problem, and usually the natural history evolves to even more bone loss, even less bone to deal with when we're going to perform our implantation. So there seems to be a track of pathologic progression. So why does this happen, and how can we stop it before we have no glenoid to deal with? We all know nowadays this concept of B0 glenoid, which was described as a static posterior subluxation of the humeral head that eventually can evolve to B1, B2, and so on. So we can hypothesize, or it was hypothesized, that this B0 glenoid happened due to an imbalance between muscle forces in the shoulder, particularly horizontal force couple. This would lead to the development of a static subluxation of a B1 glenoid, B2, and so on. So what we know from cross-sectional studies is that in B2 glenoids, we can observe a larger cross-sectional posterior cuff muscle mass that leads, or that can lead, to an eccentric glenoid wear. So it was hypothesized that this bigger mass would lead to this subluxation that would wear the glenoid. And this would eventually lead to a diminished range of motion and diminished length and tension of the posterior cuff. And what we know also is that B3 glenoids are associated with a higher degree of fatty infiltration of the infraspinatus, and this can be due to the decreased length tension given by the eccentric posterior glenoid wear. But it seems that it may not be like this. This may not be due to soft tissue imbalance. Several studies have shown that the horizontal force couple is somehow balanced. What happens is that this posterior cross-sectional augmentation of the muscle mass is probably to the diminishing, or to the shortening of the muscle. Then in the cross-section, it seems a little bit bigger. It doesn't mean that it's hypertrophiated. So maybe this is not due to a soft tissue imbalance. So what causes this? What we do know that can relate to this posterior progressive glenoid wear is humeral retrotorsion. So what we know is that type B glenoids have less retrotorsion than type A glenoids. Type A glenoids have less retrotorsion than normal glenoids. So humeral retrotorsion seems to be actually a protective factor against this progressive posterior dislocation and this progressive glenoid wear. So this seems to be a physiologic anatomy problem. This is an anatomy, a problem of the anatomy of the shoulder. So we shouldn't solve this with reproducing the anatomy. And this was probably what was in mind of Gilles Walsh and his team when they described the first results of using the reverse shoulder arthroplasty to deal with this glenoid problem, with this posterior progressive glenoid wear. And they presented their first results in 2013 with a good follow-up, and they reported a significant increase in patient-reported outcome measures in range of motion, no loosening around the glenoid, unlike what happens in anatomic cases, and no recurrence of posterior instability. But they reported a high degree, 37%, of scapular notching. So we want to decrease this bone loss progression. So this does not seem to be a very good solution, because we keep on losing bone on the glenoid side. We don't want that. So how can we arrange the reverse shoulder arthroplasty without losing more bone on the glenoid side. This is what we have nowadays as solutions to manage glenoid bone loss in reverse to the shoulder. So we have eccentric reaming, which is not very popular because when you have a big deformity, when you ream, you actually are losing more bone. You're removing that good subchondral bone that can actually give you a better fixation. You are medializing even more the joint line, which will decrease even more the tension on the remaining cuff, which will produce more fatty atrophy of the muscles that remain, and it can actually lead to a greater scapular notching due to this medialization, which actually can lead to even more bone loss. So this doesn't seem to be a very good solution in these specific cases. So this leaves us with bone grafting, so the well-known BioRSA versus the augmented base plates of reverse. So Olivier is going to talk much more deeply about this. I'm not going to go too far on this, but resuming, when you consider BioRSA versus augmented base plates, what you know is that augmented base plates are actually more expensive. They are higher costs, and they're not available everywhere. But they show, to date, a lower complication and revision rates compared to standard base plates. And when comparing to BioRSA, the BioRSA, due to the higher notching rate, has a higher complication rate than augmented base plates. It relies also on bone healing, so you have to wait in the first the first period after the reverse for the bone to integrate on the base plate. It's very, very dependent on the positioning of the implant due to the transmission of the forces. It may have a higher OR time, and it may increase the rate of infection. This is not proven. Of course, it's just theoretical. And usually you delay a little bit the rehabilitation because you're waiting for the graft to heal to avoid failure. Nevertheless, clinically, they have comparable outcomes, okay? And if you choose to use a BioRSA, or if you live in a country in which you don't have access to augmented base plates, you have better results and less complications if you do these things. If you correct the reverse shoulder angle, so if you really angulate your base plate inferiorly, and this is very important to plan very carefully the positioning of your screws and of your base plate. If you choose a long peg, so the peg usually has to surpass the graft of more than 10 millimeters, 1 centimeter, and ideally using 4 screws to fix the base plate. But when you distalize, when you inferiorize the glenosphere, you're distalizing your joint in a lateralized design, also provided by the graft that you put behind the base plate. This will lead to a scenario in which the majority of the times it will be very, very difficult to repair the subscap. So usually subscap repairability goes down. Even if you can repair it, the rate of re-tear, it's very high because it's in a lot of tension. And we don't know, we're still studying, but it seems that it may lead also to a higher acromial stress incidence. And what we also know, and this is a very interesting study, I advise you to read it carefully. It actually changed my perspective over the glenoid implant and the glenoid part of the reverse, is that the way you position your reverse has to be very well planned according to the type of reverse of glenoid that you're planning to implant. So what we know is that if you choose an eccentric glenoid, the way that the force transmits is a little bit different than if you choose a concentric glenoid. So if you choose an eccentric glenoid, there's a much more load in the inferior part of the base plate. So the center of the glenoid aligns with almost the inferior screw. So if you tilt an eccentric glenoid like you would tilt, correcting the reverse shoulder angle, like you would tilt a concentric glenoid, you may actually be increasing the failure rate of this glenoid. So this is why planning is very important, and knowing the biomechanics of your implants is also very important. So we need our Santa's little helpers, and our Santa's little helpers nowadays are the 3D preoperative planning, all the software that we can use that's commonly available from many companies nowadays. We can use navigation. We can use patient-specific instruments that are usually obtained through 3D preoperative planning. And in the most difficult cases with the catastrophic bone loss, you can use an implant that's printed specifically for your patient. So how does this work, and what are the results? By failing to prepare, you're preparing to fail. I love this sentence by Benjamin Franklin because it's true, and it's very true to our day-to-day practice. We have to prepare. Otherwise, if you fail, it's on you. Okay, so nowadays there's no excuse not to prepare very well for your surgeries. So 3D preoperative planning, as I said, is available to almost everyone. Almost whatever company you're choosing or you're implanting, they can now offer you a 3D preoperative software planning. Usually these softwares are very, very useful, and they are comproved. Their usefulness is comproved in the literature to correct the version, in these cases of posterior or anterior glenoid bone loss, or even superior glenoid bone loss in cuff arthropathy cases, and the inclination. So they give you already the measurements, and they can help you to bring your reverse to a more natural state. So they can also help you classify the deformity and can help you compare it with what it would be a normal glenoid. And this is obtained through these statistical shape models that almost every software brings. So you can put together your patient's glenoid and a theoretically normal glenoid of that patient and see what you have to correct to try to bring it back to its normal shape. It makes you prepare better. It helps you place your screws much better. Try to point them to where there's more bone stock to get a better fixation. It can help you with positioning your base plate a little bit more up, a little bit more down, and can help you choose the right implants for the deformity that you have. So this is a very small video. I'm just going to show small parts of it. This is just one example of a type of software. And this is what it shows at the beginning, all the pre-op. It gives you usually the degree of humeral subluxation, and it will give you the inclination and the retroversion. And then you can play around with your CT scan images, try to understand better your deformity and how your implants will sit on the glenoid. You can see all the osteophytes or even remove them in the software to avoid impingement. And you can choose what implants suit you better. You can try to place your screws in the better position as possible. You can see how the shoulder will behave if you place your base plate a little bit more inferiorly, a little bit more superiorly, and how this influence on how you can, the direction that you can give to your screws after positioning your base plate in that specific place. It's very, very useful, and you get used to this shoulder, and you get used to how the implants will be seated in this shoulder and in this glenoid. And at the end, you can somehow, of course, with the static scapula that doesn't reproduce the motion of the shoulder, you can simulate how this humerus will relate to the glenoid that you just placed. And then for more complex cases, for the revision cases in which you have this very, very big and usually very unique to that patient bone loss, you have also other solutions. You can have composite allografts or femoral head allografts, or even humeral head allografts that can be shaped using or with the aid of these softwares to sit and to fit on your defect. And this is a paper from the team of Ashish Gupta is doing a great job with the software Acuna, where they have all these tools to help you really plan these cases in order to decrease the number of failures and to increase your results. And also you can get a little bit more crafty. So we usually work in cooperation with the mechanical department of the technical university here in Lisbon, and we 3D print some of our most difficult cases, and we get to play around with it a little bit before the surgery, see how the implants will fit. Even if you use some plastic dough that your kids used to play, you can try to recreate the shape of any bone that you may add to try to correct this more different defects that you may have from time to time. What about navigation? Navigation has been around for a couple of years, and at the beginning was super popular. Now we're talking less and less about navigation, but navigation can be very useful, and it can be very useful because it helps you to precisely place your screws in the right position. And in shoulders in which you don't have a lot of place to actually fix your base plate, the screw placement is super important. Nevertheless, it's still not clear in the literature how this translates in clinical outcomes and implant survival. So we're still not sure if this expensive tool can improve our clinical outcomes. So patient-specific instrumentation, this is added to almost every software. You can ask them. This may be very useful, especially in cases that are difficult and that are different, but please pay attention because it can give you a false security, because the guides can be a little bit flexible, the deformity can progress, and you need to actually remove every osteophyte, otherwise you can be wrong with your guides. And to finish, patient-specific implants that are printed to mimic your defect, they can be a very good solution, and they've proven to be safe and effective in a short follow-up, but they are costly, and we need definitely longer follow-up studies. So my choice in 95% of cases is this. So I do always a 3D pre-op planning. Usually I don't rim or minimally rim. I do some micro perforations with a 1.8 millimeter drill. I use usually an augmented base plate. What I aim is to lateralize up to 3 millimeters from the normal joint line. I choose an eccentric glenoid. That's my implant of choice. I aim to spare the subscap. I don't like to leave it unrepaired. And if possible, I repair the posterior cuff. Thank you so much.
Thank you, Anna Catarina, for your presentation. Invite Olivier Verborgt from Belgium, an executive member of SECEC, to speak about Glenoid treatment strategies.
Thank you, Manos. Thank you, Maristella and SECEC, for organizing this great webinar. I hope you can see my screen now. So after this extensive introduction by Anna Catarina, I will talk a bit more about Glenoid treatment strategies. So as you know, Glenoid bone loss cases in reverse arthroplasty are not so uncommon. What about this 54-year-old active male with an important posterior wear, or this 75-year-old female with a cuff tear arthropathy and a big superior bone loss? Or even maybe less common, but still once in a while in your practice, a 17-year-old patient with rheumatoid arthritis and important medialization. This is the reality that we are talking about. So in practice, you will start with doing X-rays and CT scans, I think most of us will do, in order to assess the glenoids, to get an idea of the version, the wear, and the defects. See if the glenoid vault can actually accommodate an implant. And then finally also think about how to position that implant in terms of version and inclination. The whole key is to restore the joint line. And in these difficult glenoids, it's up to you whether you use bone or metal, or even both. And Catarina already alluded to, and I will go into that a little bit more. But it's also important to, like I said, restore the joint line and get the right inclination and version in these cases. In theory, you could look at the base of the coracoid, where in normal situation, in females, this is about 8 millimeters away from the articular surface, and in males, it's about 10 millimeters. Now, this is more theory than practice. What I sometimes use in practice, or what I like to use, is that I think that the center of rotation of the glenoid component should be actually in the middle of the acromion. This is how I try to get the glenoid back into the right position. We already heard that 3D planning is key, for sure, for difficult cases like this, where you can virtually plan your situation, where you're better prepared. And I think Anna Catarina already showed that quite extensively. And I think it's important to do that definitely in difficult cases, but even in smaller, easier cases, when you're a more unexperienced surgeon, I would definitely recommend doing this in all your cases. There's not a lot of biomechanical data out there when we should correct, graft, or augment our base plates. There's one study that shows that if more than 50% of the base plate is unsupported by bone after your standard glenoid preparation, you should do either further reaming, bone grafting, or the use of an augmented base plate. I think on the safe side, to be on the safe side, I think 70% of contact is a bit better. That's what I feel, and I think it's also important to have a solid central fixation. Eccentric reaming is one of the possibilities, but already mentioned that it has quite a bit of problems, and it's probably only limited use. There's only maximum 10 degrees of correction, and even then you ream a large volume of native bone. It's mostly the best quality bone, and you will medialize your base plate with all the negative impacts on soft tissue, tension, screw fixation, and increasing risk of impingement. We all learned from Pascal Boileau the angled bio-RSA technique. Has been already talked about, and I think this is one of the options that you have where you want to lateralize, where you want to reconstruct some uniplanar glenoid wear. The type of grafts in primary reverse arthroplasty, basically in my practice, is mostly autografts, and it's humeral head. I'm talking about primary cases, not revisions, of course, and the humeral head is there, and I think this is the best available graft. Iliac crest is the secondary choice because of its morbidity. In my practice, allografts have been become very rare because they have a high rate of resorption. Morselized grafts are more used when you want to fill up some gaps or holes, but it's not structural. It will mostly resorb, and you can only use them if you have more support than 70% of your native implants. This is a drawing that I made in one of the cadaver courses that we did, and basically you can be creative, and you can make your graft as you want or as you wish, and as you have seen on your pre-3D preoperative planning, in order to correct the glenoid wear. I think it's very important, like I said, to have a central solid fixation. I usually use a long post central in the glenoid. I do not worry about too much, even by penetration of the far cortex. I think 50% of the component should be in native bone, and then 50% should be in the bone graft. If you don't follow that rule, you'll have more failures than you want. Patient-matched implementation with PSI guides have been proven to work also in grafting procedures. We have published that in the JBJS a longer time ago, and I still will do that in difficult cases. This is a patient that I did, for example, to a bilateral case, type C glenoid, Walsh glenoid, 5 years and 3 years post-operatively with a very good outcome, and not too much of resorption of the glenoid grafts. The other way to do it and to augment your your glenoid is to use metal. The arguments for metal are that it obviates graft healing concerns. There is no reason for or no necessity for graft preparation. Definitely in revision cases, it's a good option, and it should be normally easy instrumentation while maintaining the alignment of your graft. There's been more and more literature now to compare bone versus metal. This is one of the latest good studies, a randomized control trial. Actually, they've shown that there is an overall similar clinical outcome. The elevation was a little bit better in the metal augmentation, but in the metal augmentation as well, where they used full wedge augments, there was 10% incomplete base plate seating. But most problematic, I think, is that there's still quite a bit of bone graft resorption in the bio-RSA group, which in this study did not affect the clinical outcome. See more and more studies now coming from the US, from bigger centers, that there is some concern about bone graft resorption and failure. Rotman, 25%, Mayo, 20%, and Brett Edwards, 33% rate graft resorption. And that's why I think some of us are more and more shifting towards metal. This is a case that I did, and that's what I would choose to do a metal implant. As you can see on the 3D planning, it's an older patient, 82-year-old, E3 glenoids, quite a bit of superior inclination. And so this is, I would typically plan with the 3D planners. As you can see, if you just use an augment, you can bring back the joint line where it should be without too much compromise of the native bone stock. I would do this using PSI technology, ream the high side first using a PSI guide, and then using standard instrumentation to prepare for the augmented parts on the superior parts or the low sides in order to get a right seating of the final implant. This is quite straightforward. It's not too difficult. It doesn't need a lot of preparation, no graft preparation, no concern about healing. And this is the final X-ray where I was happy with. And then finally, of course, in some cases, you will have no glenoid at all or very few bone stock. And this is, of course, a much bigger problem. You cannot build a house on sand. You will need more technology for that. You will need some custom-made implants, as Anna Catarina already said, that most of the companies now have systems available where you exactly do the same thing. You do the 3D planning, and then you have a 3D printed component ready for you. This is a case that I prepared with Materialize, which is working independent from the implant company. So you can basically use all your, you can still use your own system that you like. It's an advanced way of 3D planning your case. This is, of course, a revision case where you need much more metal and preparation. Where finally, this was the final preoperative planning results. And in the end, the execution of that was very close to what we were thinking of. So my personal algorithm for glenoid deformity in reverse arthroplasty, in a uniplanar deformity less than 10 degrees, I will still once in a while do eccentric reaming, and I use a standard base plate. I don't think we should over-engineer things. But as soon as there is more than 10 degrees of deformity in younger patients, I still like to use bone and PSI for reconstruction of the bone glenoid vault. In older patients, I do not rely on bone graft healing anymore, and I will use an augmented base plate with PSI. In complex deformities and revisions, I think you may need either the combination of bone graft augments and PSI, or in older patients, use a custom-made base plate instruments. In the future, we will see if the navigation, the robots, and so on also will help us in difficult cases. I surely hope so. And I also hope so to see you all in Rotterdam in September. Thank you.
Thank you, Olivier. I think that Anna Catarina already answered all questions. Just a quick question for you. Anna Catarina said that there are a different time for rehab, maybe a slower rehab or a longer time in the sling when you use grafts, when you do a bioassay. Is it true for you? Do you change your postoperative protocol according to the presence or absence of a graft?
Yeah, if it's an, let's say, an important glenoid defect, I use a substantial graft, I will slow it a little bit more than when I use standard implants or smaller corrections, and augments, metal augments do not need slow rehab, but I think larger bone grafting procedures do need a little bit more of patience. Yeah.
Okay, thank you very much. And now we move from glenoid to the other side, to the humeral side. And my pleasure and honor to introduce Franceco Franceschi, a pretty famous Italian shoulder surgeon, and he's going to present us his new classification for the humeral bone loss.
Thank you very much again, Maristella and Manos and SECEC for having me invited for this outstanding meeting and webinar about the bone loss in around shoulder arthroplasty. My task is to talk about humeral bone loss and talk above all about the classification, key consideration about my opinion about, about the treatment. This is my disclosure. As you know, the causes of proximal humeral bone loss are infection, as you can see here. They are really very important and very frequent. Stress shielding, look at this big stress shielding that have this pageant about the humeral using a mini stem. And the most of the time, unfortunately, it happened for a difficult stem removal, like in this case. You can see how it was wasted, the humeral stem, by the removal of this cement antibiotic spacer. Other kind of chance is an osteolysis secondary to wear debris. But proximal humeral bone loss can lead to what? To postoperative instability, of course, humeral stem loosening, and no cuff attachment. The instability is caused by a decrease of tissue tension, by decrease of deltoid wrapping, and next, the humeral stem loosening can cause an increased bending and torsional forces that are exerted on the humeral component when significant bone loss is present. No cuff attachment means that the patient can have an important deficit in external rotation and reduce the functional outcomes. So we thought how to manage this kind of problem, and above all, we had to start from the classification. But before the classification, we had to state that we have to perform a very good scale radiographs of bilateral humeri, as you can see here in this slide, and a CT scan with the 3D CT construction, which are the most famous classification. The first one was made by Pascal Boileau, as usually, that divided in 4 segments the humerus. The first one, epiphysis, less than 2 centimeters. The second one, metaphysis, less than 4 centimeters. The third, diaphysis, less than 8 centimeters above the deltoid, and the fourth one below the deltoid, more than 8 centimeters. The second one is the Ferros classification that after that I will explain to you. This classification was made by a comparative retrospective radiographic study made by 6 surgeons from 5 centers collaborated to create a classification by consensus. And it was made by evaluation of 108 shoulder region surgery using only X-ray, as you can see here, without CT or MRI evaluation. The Ferros classification, as you can see here, divided the humerus in 3 segments. 1C, calcar, 1G, greater tuberosity. The second segment is above the deltoid insertion, and the third segment is below the deltoid insertion. And the main objective of a revision surgery is a secure fixation and a long-term stability of the humeral stem, of course. And we have to fix this kind of problem with three broad categories. At first, we can use the standard implants. Second, we can use megaprosthesis. Third, we can use APC. I will explain everything, of course, in my presentation. In case of Ferrous 1 Boileau AB, at the glenoid side, we can increase the lateralization of the glenosphere, or we can use an inferior eccentric glenosphere to increase the stability of the implant. Instead, at the humeral side, we can use a thicker polyethylene, or we can use a proud stem, or we can use a cementplasty. This is, of course, the chance of increasing the polyethylene of the tray, or otherwise we can use the cementplasty, like we are showing in these drawings in this movie. It is really very effective sometimes to increase the deltoid wrapping. Other time, if you have the chance to use a metaphyseal augment, you can apply it and increase also the deltoid wrapping. In case of Ferrous 2, 3, and Boileau BC, instead, we can use the APC technique or a modular segmental prosthesis. But as for the classification of Boileau, Pascal Boileau, we have to consider that the authors told that this 5 centimeter threshold are the threshold in which an allograft prosthesis composite should be considered. So this is a quantitative classification, and this classification may not always be directly applicable to the variation found among individuals, because we are not all the same. I am different from Maristella and from Emmanouil and from Catarina, of course, and my humerus the same. The Ferrous classification is useful to anticipate the complexity of humeral reconstruction, but does not guide the surgeon decision-making regarding the choice of surgical techniques and implants. So we thought through a new humeral bone loss classification, as you can see here, percentage-based classification of proximal humeral bone loss, useful in any kind of individuals. It's almost the same of Pascal classification, because Pascal classification was really very useful and guided to the treatment, but is in percentage, as you can see here. How is possible to get this percentage? This is the formula. It's not so complex. Please take a little bit of attention to this formula. AA1 is to AB is X is to 100. AA1 is the proximal humeral bone loss. AB is the total length of the humerus. AA1 we can obtain subtracting the total length of the humerus to the remaining humerus. And with this kind of formula, we will have 4 different segments. We studied the classification, studied these 57 shoulder revision surgery operated since 2014 to 2022. As you can see here, using the scale radiograph to understand the difference between the two humerus. And from this casuistic, we studied 24 humeral bone loss. In 16 cases, we perform humeral tray increasing and increasing of the polyethylene. In 4 cases, we use cementplasty, and in 4 cases, we use ACP. These are the classification, the new classification, how it works in this way. We use cementplasty if we are in the segments of 5%. In case instead of 5 to 15%, we used to perform the ACP, and you can fix the allograft with only cement and cerclage or with a plate. Or in case of more bone loss, we can use, of course, microprosthesis. This is the humeral classification that was recently published, as you can see here, and we can say that offers a patient-specific approach, improving the accuracy of bone loss assessment, improving the accuracy of bone loss assessment, and optimizing treatment strategies. This is one of our cases, as you can see here, with a big bone loss made by this removal of the cemented spacer. We took an allograft, a humeral allograft. As you can see here, it is really very easy and funny to perform this kind of procedure, because we implant the primary implant as the primary implant we used to do inside the allograft. After that, we used to fix with cement the distal and the proximal part, and we use cerclage to improve the fixation. And this is the results after 6 months. Unfortunately, we have to let you know that after 3 years later, we have found this big reabsorption all around the APC. So we have to say that for us it's better to use cerclage instead of plates, because in case of a big reabsorption, we can have a floating plate inside the shoulder. Thank you very much.
And very nice presentation, very nice. Also, apart from your job, the presentation in PowerPoint was very impressive. So,
thank you.
In concluding, you said that we consider the proximal humeral bone loss because there are some soft tissue insertion, and these soft tissue are very important for the motion, for the rotation of the shoulder, and also it compromises the stability of the implant because we have a circular implant inside, also a circular bone, and if we have micro motion, we have micro stability, and also we have a bigger chance of failure. So in concluding, for all this, as you say. So,
yes, I completely agree. They are the most important problems of proximal humeral bone loss for me, yes.
okay. So we proceed to the last but not least, Deborah Higgs from UK. She will speak about the effective treatment approaches for humeral bone loss.
Good evening, everybody. I'd just like to thank the organisers and SECEC for inviting me to this super webinar and asking me to talk about the options for managing humeral bone loss. These are my disclosures. As has already been said in the previous talks, when it comes to managing proximal humeral bone loss, when you've got a clinical situation like this as in the X-ray, it's not just the bone loss that challenges, it's the absence of the soft tissue points of attachment, affecting your ability to reattach the rotator cuff. The absence of bone also affects the deltoid tensioning and the deltoid wrap effect, all of which can affect stability and function of your implant. And as has already been mentioned, with absence of bone, your humeral implant is relying on rotational stability on your diaphysis, which can lead to rotational micromotion and stem loosening. In terms of what are your treatment options to manage this, well, as has already been mentioned, depending on how much bone loss you've got, you can use a longer stem without graft, or perhaps overcome smaller sections of bone loss with a larger polyethylene insert or larger glenosphere, or you can turn to an APC or a humeral prosthetic replacement or megaprostheses. In terms of determining which one's best for your patient, then, as has already been mentioned, there are several classification systems that have been published in the literature, including the Ferris classification, based on the level of bone loss, of Francesco's own classification based on the percentage loss. In terms of using an APC, there are some proposed benefits. You often have soft tissue attachments on the allograft, which allows you to repair the patient's own tissue to it, with the literature suggesting that if you can repair subscapularis, you get improved stability. And if you can repair the posterior cuff, it improves function and strength. Proximal bone also allows you to improve the deltoid tension and deltoid wrap, again, improving stability. And if you manage to achieve union of the host bone with allograft, then you get regeneration of your bone stock. However, there are some potential concerns regarding graft incorporation, graft resorption, infection by introducing allograft. The cost and availability of the allograft can be quite difficult for some units to get hold of, and the perceived increase in operative time in preparing the graft. If we look to the literature, this is a paper from Mark Frankel's group looking at 73 patients. And whilst the patients themselves reported good or excellent results in 70% of cases, there was a notable complication rate and a notable revision rate. And in 10 patients, there was evidence of radiographic loosening of the humeral stem. And whilst there was a statistically significant improvement in the range of motion, there's still modest in final result with a forward flexion of 75 degrees and abduction of 72 degrees. In this smaller cohort published last year of 14 patients, again, a significant complication rate with the biggest risk being that of instability. And in two of the 14 cases, obvious graft resorption. In conclusion, the authors said that there was a high complication rate despite the fair patient-reported outcome and satisfaction. If we look to replacing your bone with metal, there are several options available on the market from various companies. In terms of how you opt to reattach your soft tissues, an element of it is determined by which prosthesis you're going to use. With synthetic meshes available, although the literature would suggest that there's no change in outcome in terms of range of motion, whether you use a mesh or not, or you can directly attach your soft tissues to the prosthesis, either through holes which are already in the implant, or several systems have soft tissue augments which you can attach. Regarding a mega prosthesis, there are some proposed benefits. It's modular, giving you multiple options intraoperatively. It avoids some of the allograft concerns of failure, non-union and resorption. And there's a perception that it is perhaps technically easier to use. Again, however, there are some potential concerns related to instability, aseptic loosening of the stem and periprosthetic fracture, and questions about soft tissue attachment and whether the soft tissues can truly heal to metal. If we look to the literature, so this was a paper published last year from the Mayo Group, looking at 53 patients, 27 of which were revision cases, all using the Zimmer Biomet SRS system. Again, significant revision rate, the most common indication being aseptic loosening, and similar range of motion outcomes as that in the papers for the APCs. Regarding complications, they looked at soft tissue attachment of deltoid and felt that the complication was not related to whether it was affected or not, although they did feel that it may improve the patient's external rotation. Regarding the risk of revision, the number of previous surgeries was a key link to this problem. Regarding this paper published 2 years ago, this is looking at a different system by Exactech, with 30 cases being due to a failed arthroplasty. Again, similar functional outcomes, similar complication rate, the most common being instability, and an overall 12% revision rate. When it comes to restoring rotation, I'm sure everyone's familiar with the description of the Lepiscopo transfer as described by Pascal Boileau. And that is something potentially you could consider with a mega prosthesis. However, looking to the literature, there is nothing that I've been able to identify which describes this or gives a potential advantage in terms of rotation, but perhaps something to consider. When you're looking to directly compare the various treatment options, this is a paper which was published literally last month, looking specifically at humeral bone loss in the ferrous 2 group, so that's in the metaphyseal diaphyseal area. And the purpose of the study was to compare the complication and reoperation rates between patients where they had an unaddressed humeral defect versus those who'd had an APC versus those that had had a megaprosthesis. Exclusion criteria was bone loss less than 3 centimeters or more than 7. And in their results, they could find no significant difference between the VAS score, forward elevation, or the symptomatic complication rate or reoperation rate, leading them to conclude whether you needed to do anything at all in this group of patients with bone loss, although carefully saying that you couldn't necessarily transpose their results to more significant bone loss. In terms of my approach, if there's very small bone loss, so less than 4 centimeters, I will try and overcome that with a thicker polyethylene insert or a larger glenosphere. My implant of choice has a 135 neck shaft angle and lateralizes off the glenosphere. So perhaps something to consider depending on what system you use. But when it comes to more significant proximal humeral bone loss, I tend to turn to a megaprosthesis rather than allograft. I always assess the bone loss preoperatively, as has previously been described in other talks, with plain X-rays, CT scans, and contralateral X-rays, measurement films. However, the final construct and the amount of bone you're replacing with metal is always, for me, determined intraoperatively based on the soft tissue tensioning. I try and preserve the tuberosities if possible, although in reality, particularly in a re-revision setting, that's often not possible, they're not present. And the same is true of the rotator cuff. If the deltoid insertion is involved, then I do try and reattach it to the prosthesis. I go very slow post-operatively with these patients. They're in a sling for 6 weeks with hand, wrist, and elbow exercises only. And at 6 weeks, when they do come out of the sling, it's slow and gentle physiotherapy rather than a particular target in mind. This is a case taken from my practice. So this is a 56-year-old patient who was a manual worker who sustained a proximal humeral fracture. And by the time this X-ray was taken, the patient had had 4 operations to try and overcome the bone loss with ever thickening polyethylene inserts. And as you can see, it's not truly succeeded. So this was revised to an APC, which unfortunately did not manage to achieve stability. And I don't know how well this projects, but if you look at the deltoid shadow, you can see that it's rather thin, and this patient had unfortunately also sustained an axillary nerve injury. So this was revised to a fully custom proximal humeral replacement with a captive liner, which is something that we occasionally use where I work at Stanmore. And this patient has now had this implant in for 5 years. And whilst they have no pain and a stable shoulder, function is very much limited to waist level. So in summary, managing this kind of bone loss is challenging. I think it's important to recognize not only the quantity of bone loss, but the quality of what's left. I think if you can reattach the soft tissues, but I think it's important to do what works in your hands and to plan carefully. Thank you.
Thank you, Deborah, for this great presentation. I want to thank SECEC for giving us this space tonight, all our faculty. You were great. You just make very difficult concept very, very easy and clear. But most of all, I think we're gonna say thank you to all the participants, because you really share your enthusiasm with us, with a lot of questions that our faculty is still answering probably. So thank you all.
Thanks to SECEC for this wonderful webinar. Congratulations, Maristella, for selecting the topic. Thank you everyone for the faculty for impressive presentation. And I would like to invite everyone to be a member of SECEC if it's not until now. and be there in the next Congress in Rotterdam.